So hello everyone and welcome to this webinar. This is the 5th webinar we are organizing in our Qualitative Health Research series, which is hosted by the Developmental Pathways for Health Research Unit and the Center of Excellence in Human Development at Wits University here in Johannesburg, South Africa. My name is Sonja Klingberg and I'm a postdoctoral research fellow at the Developmental Pathways for Health Research Unit, DPHRU. I'll be chairing this panel discussion today with 3 experienced scholars who will be talking about engaging with medical anthropology to understand health and disease. And so our 3 speakers today are all in some way connected to the research unit I already mentioned here at Wits University, the Developmental Pathways for Health Research Unit. So we first have Professor Emily Mendenhall, who's a medical anthropologist and professor at Georgetown University's Walsh School of Foreign Service, and also an honorary researcher here at the University of Witwatersrand. She has published widely at the boundaries of anthropology, psychology, medicine, and public health. In 2019, she published Rethinking Diabetes, Entanglements with Trauma, Poverty, and HIV. And her newest book is forthcoming this year, 2022, called Unmasked: COVID, Community, and the Case of Okoboyi. And then we're also joined by Dr. Michelle Pentecost, who has dual training in clinical medicine and medical anthropology. She's a lecturer in global health and social medicine and a UKRI Future Leaders Fellow at King's College London, and also an honorary researcher here at Wits at DPHRU. Her current research here in South Africa investigates the social and ethical implications of public health interventions in the early life period from preconception to early childhood, and also develops innovative qualitative methodologies for studying the social factors that shape life trajectories. And last but certainly not least, we have a regular source of wisdom on our qualitative health webinars, Dr. Edna Bosire, who is a postdoctoral research scientist for the Blantyre Prevention Strategy unit at Georgetown University Center for Innovation in Global Health, and also at Kamuzu University of Health Sciences in Malawi. She is also a researcher here at DPHRU at Wits University. And her research interests include health system strengthening in Africa, HIV and AIDS, diabetes, mental health, adolescent health, and nutrition. So now I would like each speaker to tell us a bit more about their work and perspectives on medical anthropology in their own words. So we're going to be starting with Professor Mendenhall. So if I can ask you to start, Emily, please.
This is such a privilege to share this space with you and share a little bit about my work in South Africa. But as anthropology goes, it started much earlier in my training when I started reading about trauma and diabetes. I started, when I was doing my doctoral research, I started reading the literature on diabetes that had been written in anthropology, and a lot of it was narrowly focused on the Americas. At the time, and this was, in the early 2000s, not a lot had been written about the experience of diabetes outside of the West, or how people even were conceiving it beyond food and the ways in which people ate and conceived of, especially in the West, there's particularly victim blaming narratives and constructions in the clinic, but also in larger society around why people get diabetes and how they experience it. So I started digging into this a little bit when I was in Chicago. I did a study on trauma, on diabetes, and I found that trauma was at the center of many people's stories and other things like social isolation. And then I spent a year in India because I was invited as a fellow to study what diabetes looked like across income groups, because there were early studies indicating that diabetes was starting to affect lower income folks. And we were trying to understand how that experience might be a bit different. And then Shane Norris, after my year in India, invited me to do a similar study on the experience of diabetes in Soweto. And at this time, there was some physical, biological evidence of diabetes emerging, but no one had done any qualitative work around it. So I was really excited to come to DPHRU, and this was in 2012. And I just spent a number of months listening to women's stories who are part of the Birth to 20 cohort as a postdoc. And I started to realize the entanglements of not only trauma or depression or social relations that were entangled in diabetes, but also narratives, not just of the physical experience, but the social experience of HIV, and how constructions of past public health campaigns and the experience of HIV or malaria, how people talked about other infectious diseases, were really affecting how people were talking about and thinking about diabetes in a provocative and impactful way on how people conceived of the illness or shared their illness or acted around caring for themselves. I thought that was really fascinating. And then a few years later, I was able to go to Nairobi and meet Edna, who will speak later, who has become an incredibly important partner as I travel through my career. But at the time, I did this first study in Soweto, and then I was able to come back a few years later, which Edna was a part of, and do a study on looking at how the experience of cancer was, especially with care seeking at Barra, impact how people kind of thought about health and wellness. And I started to shift a little bit from looking at, how people, and this was really research led, because one of the things about anthropology is you can read all you want from hopefully multiple disciplines about your question and what you're studying, and spend a lot of time listening to people and really putting people's perspectives and, interlocutors, especially at DPHRU, there's such a rich collective of knowledge of people who've worked there for decades, who work in partnership, and really who can lead the research. So, some of these questions about what it means to live a good life and have good health were starting to center in my research at this time. And then we ended up, I'll quickly try to travel through the last bit. We just finished a big project where we had used these earlier ethnographic projects to build locally relevant scales. So we could look at, how people conceived of stress in their lives around chronic illness or multiple conditions, and also how people coped or managed or lived well with multiple conditions. And we built these two scales, a stress and coping scale, that then we administered to about 957 people to kind of capture how common these trends were among people with and without illness, or with multiple conditions or one, and what that really looks like. And what we found in a recent paper in Nature Human Behavior, which is exciting because you can actually publish anthropology in these scientific journals and really etch away at the narrative, the biomedical narrative, and kind of insularity of belief of biology is centered in how we think about and experience illness. We found, that stress was a profoundly impactful moderator of well-being compared to chronic illness, which in public health and medicine, illness, the biology, the disease is so commonly centered in how we conceive of healing and caring and living. So also along the way, so we did this wonderful study, which I think is just really interesting. But our colleague Lindele Sele also led a study on flourishing. And we have a wonderful paper that really centers what it means to live a good life and have good health. So coming full circle, you can see she really led those questions, and I've always worked in teams because I think I always learn the most in teams. I don't find the history of a singular anthropologist working alone is ever that beneficial. So, working in teams, we were able to do some really innovative work. And I've learned so much from my work in South Africa and from the team, especially from all of my colleagues at DPHRU. So I think that's a good introduction. So thank you.
Absolutely. Thank you, Emily. And you've definitely covered a lot of interesting perspectives and topics already that we'll hopefully have plenty of time to go into a bit more as well. Could I next ask Michelle to give a bit of an introduction about your work as well? Thank you.
So I'm going to focus specifically on a new project that I've just started with the Healthy Life Trajectories Initiative, which is based at DPHRU, as a way to give some examples of what medical anthropologists might contribute to this work. So let's see if I can get the slide to go. There we go. So Trajectories is a social science collaboration with the Healthy Early Life Trajectories Initiative. And many of you will be very familiar with the study already if you know and work with DPHRU. It has cohorts in Canada, India, China, and South Africa, where I will be working. And it's a multi-sited preconception trial. And it's testing the hypothesis that preconception interventions can optimize a young woman's health, and that this might have an impact on childhood obesity rates as well as early childhood development. So where does this come from? It's the outcome of a few processes coming together. First, the WHO ECHO report on childhood obesity, which indicated the need for some kind of global action plan for childhood obesity. Second, as is illustrated in this slide, again, many of you will be familiar with the established interest in life course approaches now to understand NCD risk, and that we have these really important critical windows of potential influence in early life, including pregnancy and early childhood. And then finally, the outcomes of previous trials looking at behavior change intervention in pregnancy and finding that actually it has quite limited effect, and that perhaps pregnancy is what epidemiologists are calling too little too late, that it's too limited a time span for intervening in that way. And that perhaps maybe preconception is where we should be targeting our interventions. And then at the same time, a lot of work that's been done in medical anthropology already around intervention in pregnancy and how this potentially foregrounds women as the individual responsible agents for health outcomes with its own side effects, including gendered and racialized frameworks of responsibility. So this is kind of where this collaboration comes from, working against a kind of paradoxical issue, which is that we have interventions that are hopefully designed to attend to the social determinants of health, maybe even in intergenerational frameworks, but that these do have the potential to reinforce other social structures that we are in fact seeking to alleviate. So the crucial question then for the Healthy Trajectories collaboration is it possible to build life course interventions that can account for social systems and in fact decrease inequities in health? So about the Healthy trial, as I've said, it's the first global study that will test a preconception intervention for its possible intergenerational impacts. It's hosted by DPHRU. The trial setting is Soweto. The aim is to recruit around 6,800 women, which statistically will give us about 1,500 pregnancies. It's a complex intervention, including micronutrient supplementation and a suite of behavior change interventions from preconception through to pregnancy and early childhood. The primary outcome is child adiposity at age 5, and then there are a host of secondary outcomes around early childhood development. So what we have here from a medical anthropologist perspective is some really crucial opportunities. First of all, is preconception the right target for a life course approach? And that's really the crucial epidemiological question that can be answered here. But also, can we deepen our understanding of the mediating factors that shape these different life trajectories through some medical anthropological work alongside the trial? And then also of interest are the potential challenges of this kind of work. So this isn't a birth cohort. It's even longer and bigger than a birth cohort in terms of its trial timeframe. So it has new methodological challenges that potentially an anthropological lens can assist with. And then can we avoid a kind of gendered approach that burdens women with responsibility for future health outcomes? So the Trajectories Project attends to this in kind of conceptual and methodological ways. So the first component of my work with Healthy is what we're calling the social life of a preconception trial. So using methods from anthropology and bioethics that look at the institutions, the networks, the ideas, the practices that bring together the trial that help us understand what it means to intervene preconception and how we might frame that and act on that in a way that promotes rather than undermines equity. And then the second component is about methodology. So this is proposing a 5-year qualitative longitudinal study with some of the women who are enrolled in the trial using ethnographic participatory methodologies. Again, coming back to what Emily has said about exploring how health comes to matter for people in their lives, generating insight into the social context and allowing us to generate hypotheses through discerning differences and patterns. And really centering the participants as the key stakeholders in the trial and ensuring that the trial outcomes are maximally responsive to local context. So I think medical anthropology has an opportunity here to contribute to producing an evidence base that centers justice and equity. And I think importantly for the Healthy trial, the utility of the preconception framework really hinges on whether we can use it to capture this broader set of social concerns and promote rather than undermine equity. And hopefully having the anthropologists on board is going to help us to achieve that aim. Thank you.
Thank you very much. Very interesting and some more topics as well that we can hopefully dive deeper into. I'd like to move over to Edna for some opening remarks about your work, please.
So basically, Emily introduced most of the work that we do together. So I've worked with Emily. Actually, this is the 8th year now. We met in 2014. So we've been doing a lot of studies together. And I'm happy I learned more about Michelle, and maybe we'll continue working together in some of her projects that she just talked about. So basically, just to talk about some of the projects that I've done, we started from a mental health institution where we were doing research. That's when I met Emily, and we started doing this mental health work, trying to understand the social experiences of patients with depression, with diabetes, and with other conditions. But then we realized that some of these patients with mental health issues have other physical morbidities like HIV, diabetes, and that is how we developed, I developed an interest to see how does the healthcare system manage such kind of patients. And as we were trying to, to explore what was happening in Nairobi, Kenya, that is when Emily invited me to join her in Soweto, South Africa, to continue exploring the same kind of questions. And that formed the basis or the foundation of my PhD work, which looked at patients who have HIV and diabetes together. How is the healthcare system, structured to take care of patients with comorbidities and multimorbidities? And you might realize that nowadays, when we have these patients with chronic conditions, rarely does a patient just talk about one chronic condition. They either have multiple other conditions, both non-communicable or communicable diseases, or they have chronic social stressors that even make their conditions become difficult to manage. So I did my PhD at DPHRU and looking at HIV diabetes, not only focusing on patients, but also looking at the healthcare system, how the healthcare system was structured to take care of these patients. And while at DPHRU, again, as Emily mentioned, it's a cohort of, we have so many researchers doing different projects. So, and our director is very, very generous. He allows students to navigate through and join whichever project they want to join in. That is how I was able to pick some of the projects that I'm interested in. For example, Healthy, one of them, but also at the same time, Emily got some funding for us to do 2 big projects. That is the cancer study and the NIH-funded Soweto syndemic study. So I was part of these studies and we continued working as a team, and we've really published a lot. If you check some of our profile online, you will read some of the publications from the various pieces of work that we've been doing. But other than HIV diabetes, so looking at HIV diabetes as single diseases, but also how they overlap and how patients who have multiple diseases then take care of themselves, or how these providers take care of these patients. So I can say that my research interest, as Sonia mentioned, is really centered around healthcare system, health system strengthening, and also, the patient experiences, but also looking at the issue of mental health, because we can't really divorce mental health when we talk about patients with HIV and diabetes struggling in some low-income settings. Some of them will report issues to do with depression. Some of them will talk about suicidal ideations or stress and so on and so forth. So some of the methods that I've used to do my work are mostly ethnographic because I'm an anthropologist by training. So some of the ethnography, I've done both community ethnography and hospital ethnography. So at the community, I try to understand how people's daily lives, including culture, belief system, the socioeconomic factors, how it impacts not only them to be sick, but also how it hinders them to access healthcare, or even how some of these factors are supportive to enable them, thrive, as Emily talked about the thriving paper. But other than looking at the social factors, in Soweto, I did clinic ethnography. This is some of the spaces that most people don't believe that anthropology can do work in the hospital. I actually stayed in the clinic for over a year at the diabetes endocrine clinic at Chris Hani-Baragwanath Hospital. And what I was trying to study here or to explore was the culture of biomedicine, because even doctors and nurses and clinics, they have their own culture, they have their own way of doing things that is shared within their own communities of practice within the hospital. So trying to understand how is the system structured, who does what, and also trying to study the protocols provided or guidelines and trying to observe, are people doing what is actually provided in the protocols. So other than community, there's this clinic ethnography, and also other than observations, I do a lot of in-depth interviews. And Emily mentioned about us doing lengthy interviews. We actually spend up to sometimes 3 hours with a patient. So we might end up doing only 1 interview or 2 interviews in a day because they are really lengthy and people want to talk about their experiences and their issues. So other than in-depth interviews, I've also done key informant interviews, talking with the experts in specific fields, depending on the research questions you are trying to answer. And also, as Michelle talked about, I've done a lot of focus group discussions. And these focus group discussions I've done both for adolescents and young people and also adults. So depending again with the research questions we are trying to answer. So currently in Malawi, what I'm doing is in the field of implementation science, but then bringing my anthropological skills and expertise in the field of implementation science to see how we can then incorporate anthropological theories and frameworks to the field of implementation science in terms of participatory approaches and others like citizen science approaches to ensure that whatever we are studying, we are incorporating people from the data collection phase. We don't just talk to people about our findings, but they are part and parcel of our understanding of the key research questions we are understanding. And I believe that solutions actually lie with the communities. If these communities are empowered and are given the right tools to try and address their own issues, they are the experts. They know what is their problem and they know what solutions are needed. So that is what I'm doing here in Malawi. The topic is on HIV, but of course, HIV will cut across other social issues. So I'm working with the community leaders, chiefs, village heads, but going all up to the city councillors elected to serve their communities, and district commissioners, district officers, people at the district health office. So it's actually cuts across. We are not using a top-down approach or even a bottom-up approach. We are using whichever direction to ensure that everybody is brought on board to address the health issues that affect populations. So I'll stop there and I'm glad to answer more questions after this. Thank you.
Great, thank you so much. Very interesting to get an understanding of all the different types of questions and topics and levels and perspectives that medical anthropology allows for when it comes to health-related research. You all talked a little bit about your journey to DPHRU, or the kind of work that has brought you to be connected with DPHRU. And I was wondering if you could tell me a bit more about the training that you've had, what kind of disciplinary perspectives you bring, whether within kind of anthropology or at least, as I mentioned already in the case of Michelle, also the medical training. So maybe we could start with you, Michelle. Can you talk about your training and how that informs your work? Thank you.
Thanks, Sonia. So I think Emily really captured something about, I think, the kind of anthropologists that we are in terms of working in teams. I don't think that I would count myself as a lone anthropologist either. So I trained in clinical medicine at the University of Cape Town, and I worked as a clinician for a number of years before shifting to a research career. And I chose anthropology because I really wanted to break out of the biomedical paradigm, and it seemed like a good way to do that. And I think what I appreciate about having the medical, but also the anthropological perspective is that I have an understanding of the different languages that we use to talk about and do research, and they all have their benefits. So I'm really invested in interdisciplinary work that can genuinely use the best of all of these tools together to answer questions in potentially more complex or nuanced ways than we can do if we work in our siloed disciplines. So I find DPHRU is a very welcoming environment for that kind of perspective. And I think the unit has been as successful as it has been because it enfolds these different disciplinary orientations. So yeah, looking forward to continuing those interdisciplinary conversations.
Great, thank you. Michelle, oh, sorry, Michelle, you already spoke. Emily is who I was looking at next. Could you also give us a bit of background about your training and how it relates to your work?
Sure. I'm not a clinician, but I share a similar story to Michelle. I was very interested in medicine for a long time and then shifted because I decided to want to look at bigger questions, and I studied public health. But while I was doing that, and then I was working in public health, I realized that the depth of the problems were glossed over, and that we couldn't really understand the heart of the matter. And so I ended up chumming around with some anthropologists because I thought that how they spoke and explained to me how problems, the heart of the matter really made sense. So I started reading. And as I was practicing, and I worked a little bit in Guatemala, and then I was working in Chicago, I decided I wanted to dig deeper, and I ended up studying for my PhD in anthropology in Chicago as well. So I had this strange experience where I was at my field site. I worked at the big public hospital called Cook County Hospital in Chicago for 5 years alongside of studying for my PhD. So I was really consistently doing research and studying at the same time. And I really see that as crucial to how we do anthropology, consistently listening and learning and doing field work, doing research while reading in depth and continually keeping up with and really framing how others have written and thought and interpreted these questions that we were asking. So really moving between the literature and participants is really crucial. But the point I wanted to make, which is very much like Michelle's, is that coming from public health, coming from medicine, we're much more likely to be problem focused and collective in our work habits. So I think that many, and there are kind of divisions within the discipline as well, as people really, being concerned with, okay, let's explain and unpack this problem. And then others coming from a even more expansive ground up perspective, doing larger, broader ethnographic projects that may not be solution or problem focused. So I think that does come from our trajectories. And I find it to be, because one of my objectives is to make interventions that change how people think. And I think Michelle and Edna share these goals to shift how people think across disciplines and not just stay within an anthropological scholarly dialogue. Because for me, that's never been a goal, because I think together we can kind of move and understand and transform how we do and care for people globally by having these broader conversations. So
Great, thank you so much, Emily. And Edna, could I ask you the same question as well about your training and how it informs your work?
Yeah, I'll try to be brief on that because most of the points have been highlighted by Emily and Michelle. But one thing that most people don't know about me is that I really wanted to become a medical doctor. I didn't want to become an anthropologist because in Kenya, most people don't know what anthropology is. So it's actually one of the courses that is looked down upon. And sometimes you will hear our ministers of health saying, maybe we need to scrap anthropology from the curriculum. So after my high school, I joined medical school for 1 year to train as a doctor. But then I later shifted and came to do anthropology for other reasons. So the university had asked me also to do anthropology. So I joined to do anthropology. And that is why I lean towards medical anthropology more than other subdisciplines of anthropology, because we have cultural anthropology, we have archaeology, and other subdisciplines of anthropology. And so, yeah, in terms of what I bring to DPHRU, or to kind of the research that I do specifically, is research methods. So in anthropology, there's a way we are trained, and there's this extensive training in specific research methods such as ethnography that you might not see it more often in other social scientists. And I saw a question in the Q&A from Maureen Joffe asking almost the same question. So some of the frameworks that we use as anthropologists really of course, they are informed from our training, but the way we see things, I'm not trying to say that anthropology see things in a more better way than other disciplines. But what I'm saying is that there's a way we look at diseases and illnesses, for example, and what we put at the center of our frameworks is the issue of context, because we believe context matters a lot, and context informs everything that we do. That's from the methods to the research questions to how we conceptualize our studies, not specifically using kind of structured ways, but trying to explore things from what is happening in societies and what are people talking about and which language are they using to communicate, and what other issues are they experiencing and who matters in the community to these people, and who are the key decision makers in these people's lives. So looking at all these aspects and many others that I might not have said informs some of the frameworks we use, informs how we look at things, and informs the kind of studies we do. And I think this is what I've added to DPHRU. For example, I've trained some of my other colleagues at DPHRU who are not conversant with some of the anthropological methods, but also in terms of publications, because as anthropologists, there's a way we do our writing, which is not very conversant, for example, to the discipline of public health or medicine. So this is something that we also contribute, and of course, trying to engage in a very positive debate with our colleagues from other disciplines to see and to show them what we do and how we can always integrate it. And for my PhD, I did actually an interdisciplinary PhD, having a medical anthropologist, Professor Mendenhall, as one of my supervisors, but having Professor Shane Norris from epidemiology and Professor Jane Goods from who's done a lot of work on health systems as my supervisors. So all these three supervisors, as you can see, they came from different disciplines, but the way they were able to help me see how I can always navigate through across disciplines and see health and disease from different lenses is something that has helped me and is even helping me now as I engage with other epidemiologists here who don't know about anthropology, but I have to say we have a stake to contribute in the field of implementation science. Thank you.
Great, thank you so much. And thank you for setting up a nice bridge to our questions that we've started getting from participants. Thank you so much. I saw that some written answers already got shared there, but I wanted to ask if Emily, would you like to comment on this question around methods further?
Yeah, sorry, I just started answering.
No, feel free, but it's nice if we can keep a discussion going as well. Sure. But maybe I should read out the question and then we can continue. So there was a question, do different social scientists use common tools, for example, in-depth interview to ask research questions from different discipline frameworks? So Emily, do you want to kind of repeat a little bit of what you wrote there already, and we can see if Michelle or Edna want to add something as well.
Sure, I'll answer that and move beyond it because I think there's a larger relevance that both Michelle and Edna can discuss and lead on. Yeah, I definitely, so traditionally anthropologists have been very much community-based and ground up, basically doing broad, deep ethnography on the social experience. which has shifted. Laura Nader was writing in 1972 saying anthropologists really need to tackle the complexity of elites and how elites craft power and institutional relations. And I would say that still that work is nominal. So Svea Klosser and I and Judith Justice and Peter Brown and Rachel McNeil just published this review in Social Science and Medicine on that research on ethnographic approaches to health policy and systems research. And Edna and, and Michelle have done work in this space. And, I think Edna can speak pretty broadly about that work, but really moving to do and use ethnography, which some political scientists do, to study systems and the powerful. And how they work is something that I think it should be a priority in anthropology, but has still been sidelined in part because of some disciplinary biases against studying elites. And that is just kind of disciplinary. And, political scientists who have traditionally studied elites and the powerful and institutions and politics itself have traditionally really stigmatized those who do qualitative work. It's been, while it's been the bread and butter of anthropology, it's been really looked down upon in political science. So political scientists who do this work call themselves qualitativists. and they do really good work and, often bridge the gap between the disciplines because, disciplines are somewhat artificial and were built for certain reasons, although working together and reading across disciplines can be most fruitful. One of my mentors, Peter Brown, years ago said, if you bring one idea from one discipline to another, people will think it's brilliant when everyone in the other discipline is like, well, that's our bread and butter. So really being able to communicate these ideas across fields can be useful. And this also relates to the other question of communicating your findings and speaking to a broader audience. And I provided a little insight there, but I'll stop because I know my colleagues have much more insight into this.
Thank you. Yeah, that's very, very interesting. And I like that we're going into the topic of interdisciplinary working a lot throughout. It's definitely something very interesting and important to cover. Michelle, would you like to comment on the questions around kind of tools and methods, or also something that Emily already raised there?
I think I just say I completely agree with Emily that anthropology has traditionally potentially overlooked these really important groups of actors which are useful to study. So as I was mentioning in the project that I'm working on now with Healthy, it's not enough to do work with the participants in the trial. What will we learn if we actually consider the trial scientists and the people who run the trial and who conceptualize the trial as research participants themselves? What might we learn about how trials run and how they might run better if we think in that way? So I think touching on a point that Emily also made earlier, the kind of big difference sometimes is that we don't need our research to necessarily be problem focused at the outset. If you start with a slightly broader framework, you generate hypotheses as you go. And I think that is sometimes something that's a bit difficult to wrap your head around if you come from a public health or positivist background, that you don't necessarily have a goal right at the beginning, that this is the thing we're going to go and figure out. That open-endedness, I think, makes some people quite uncomfortable, but I find it really, really generative and exciting. So hopefully that adds something to the conversation.
Thank you. Yeah, absolutely. Edna, would you like to add to these comments and questions?
Yeah, I like what Michelle finished with by saying that we not only really focus on problems, but also look at opportunities, because more times when people do research, or when you ask them what is your research aim, or even students when they are conceptualizing their studies, it's like trying to find out a problem. But sometimes you might, see what is working in, for example, community A or community B. And that takes me to the other part of how then do I conceptualize my questions, for example. So it also depends not only on the problems, but what people are talking about, what is happening in the community at that time. and what my experience has been, and also what is the topical issue. What is, for example, if we have issues of climate change, how is it impacting people? We don't have to wait until we have problems to start studying such kind of concepts. So, and also going back to what Emily said, anthropologists for a very long time have been, perceived as people who study the minorities, the poor, children, people who are really vulnerable at the communities. But then we say, like most of the work we've done with Emily, including my PhD, I not only look at patients, but I also look at powerful people in the society, in the community, the healthcare provider. Remember, all of us know the divide between a patient and a doctor, for example. Like a doctor is the one who makes decisions for the patients, but we try to study both of them to understand what is happening, and do they even understand about this gap between the patient and the doctor. The same thing happens to the community where I am right now. I'm not just trying to study issues related to a particular disease, but I also try to engage with the people who are making policy. At the end of the day, no matter how interesting our findings are, if we don't bring these people who make decisions on board to follow or to come with us through the whole journey to understand, then we might not be able to help the communities or the population health that we are talking about. So cutting across all different levels in society, the powerful, the minority, the people who are there, the people who seem to be meaningless is very important. And I think that is what most anthropologists are doing. Yeah, thank you.
Thank you, that's very interesting. I wanted to bring in a question from Astrid about how you as anthropologists deal with criticisms around who is seen as responsible for health related things. So the question here specifically was about placing responsibility on women when it comes to preconception health. But if you have some broader comments also around how anthropologists would address the kind of blaming, or as you were talking about problems and how problems are framed, you can talk more broadly as well. But we could maybe start with Michelle, who might have some specific thoughts on this around healthy and the kind of topic of preconception health.
Thanks, Astrid, for your question. So as I was mentioning in the little presentation, we've had a lot of work in epidemiology that focuses on intervening in pregnancy. I'm sure you've all heard this phrase, the first 1,000 days from conception to the age of 2. And that particular policy angle was in fact the focus of my own PhD work. So certainly we have quite an established, I think, corpus of work in anthropology now that has highlighted the potential problems of focusing in on what we might call the dyad, the mother and the child, to the exclusion of fathers, other partners, other family members, other community members, the collective in which children are in fact, conceived and raised. So there's already quite a lot of work that has highlighted this and how policy might be more successful if it frames things in such a way that we talk about caregivers, for example, rather than mothers, because we know, for example, in the South African context, that the nuclear family is not the standard pattern of how people live with each other. Certainly the mother is not often the default caregiver. We have all kinds of flavors of family relations that make up what the South African family looks like. So there's a huge body of work that's spoken to that. So I think the challenge that I'm really interested in addressing with my new work is when you set up a trial, you do need an index subject. And when it comes to cohorts of this nature that are interested in early life intervention, then it is often the reproductive woman who is the most useful index subject, because of course, this is the person who's going to engage with medical services. This is the person who's going to be on the receiving end of a lot of health policy. So of course, practically that does make a lot of sense. But in what ways can we shape the intervention such that it accounts for the fact that these women are members of communities and families and societies and collectives? And they're very simple speculations we might even make at this point, based on some of the pilot work in Healthy, around what is of interest to these women. For example, financial literacy. which is certainly an intervention which reaches beyond their capacities as reproductive beings. So I don't know if that gives you a small flavor of some of the things that we're thinking about. Yeah, I don't know if maybe Edna or Emily has anything else to add to that.
Thank you. Yeah, Emily or Edna, would you like to continue on that topic, or do you feel that it was covered?
Yeah, I think
Edna,
Michelle has answered. Thanks, Sonia. I think Michelle has answered quite well. And of course, she's an expert working in this topic. What I just wanted to say is that most people, when we talk about preconception, people focus on the word conception, and even the pre-word goes like escapes from people's head. We are talking about a woman before she becomes pregnant, before she conceives. And there are a lot of things that happen. So going back to the methodology, there are a lot of things that happens in this woman's life, what she eats, where she lives, who are her social networks, for example, even her boyfriend or husband or whoever who is now making her pregnant, for example. So all these factors, when brought together, will influence the preconception, life of this woman. So I think Michelle has put it in a very, very appropriate way, but I wanted to say there is life before this woman becomes pregnant. Thank you.
Thank you. Yeah, important to note. Emily, did you want to add anything to this topic?
No, I think that they covered everything really well. I could add one small note that, so Edna and I have both been doing these projects on COVID in our hometowns. There's a really big difference doing research in your hometown versus a place you have not grown up. And so I think there's some really interesting, and one of the great things about DPHRU is that there are a lot of people from Soweto, from the community, who have long worked at the unit and partner with different researchers, but obviously being a foreigner, what the research is and what you do with it really matters, especially obviously in your community, but when you're working and writing on your own community, there's different ways and you see research and talk about it because it's linked to your family. And so I think especially when you're working in a community you haven't grown up in, you have to be even more careful about how respectful and engaged you are with the research, because you may not know how your research could affect someone if an identity was revealed, for example. So being, engaging with work also comes with such, especially me being a white foreigner, what does this work mean? And who am I to do this work in general? So, really thinking about who does the work, who names the work, how those involved are protected, and how people's perspectives are at the center of what you're doing really matters in everything that you do. So it's just something to really think about. And this is something as a discipline in anthropology and also in global health. These are ongoing conversations about whose voice matters and why. And those are just crucial conversations that we need to continue having.
Absolutely. Thank you for that. And thank you to everyone who sent questions. Feel free to send more. We do still have about 10 minutes remaining. But I wanted to follow up on what you've all been raising around interdisciplinary research and also working in teams, and kind of continuing from what Emily was just talking about in terms of addressing practices from the past, perhaps. So about anthropology as well. You've mentioned the lone anthropologist, and obviously the dynamics of studying someplace far away from home has been the typical setup of anthropological research. So could you talk about how you try to address those things in your work? We already heard from Emily, but Edna and Michelle, something around, for instance, teams or other approaches, and ways in which you also reflect on that, because it sounds like you all have that quite kind of at the top of your at top of the agenda of your research. So Edna, do you want to start with that, if that question made sense?
Sure. Yeah. Thanks, Sonia. Yeah, so as I mentioned, first of all, for me, I will give my own experience. Like, first of all, being supervised by 3 supervisors who are across different disciplines was an experience by itself, because a supervisor who is an anthropologist, I'm sorry, Emily, I'm not pointing fingers at you. So an anthropologist, there's a way an anthropologist would like to see things done, and then an epidemiologist, there's a way an epidemiologist likes to see things done, and it goes all the way to the other a supervisor. It's not just about writing, but also in terms of publications. Someone will say, this is, I want you to maybe submit to this journal, because that is where maybe those are some of the journals that maybe impact them, or they like those journals. So I think it took me a lot of time and of course patience to learn how to navigate, because sometimes you don't know, but then you have to learn how to create a boundary, because you don't just take everything that you're being asked to do. And this thing transcends down to doing research. I do a lot of collaborations, interdisciplinary collaborations with different scientists, and some of them totally don't understand anthropology. So I take time to explain myself what anthropology is and what my contributions are. And some of them actually will like rubbish off what you are doing, try to show you like, you know, there's this kind of disciplines feeling superior or perceiving themselves to be superior over other disciplines. So that is a challenge that is outside here, but trying to learn how they do things and not to undersell myself as an anthropologist, because I know there's something I have to bring at stake, but also trying to respect them, but also try to explain to them how we do our stuff, the methods we use, how we engage. And that over time, I learned that people really learn about myself, learn what I do as an anthropologist and accommodate me on the table. So we continue doing the same kind of work, and people are now learning how we can contribute to the field of global health, whichever discipline, health discipline that we are working on. So it's all about creating collaborations, creating rapport, respecting other disciplines, but also letting them know that they should respect you so that you don't undersell yourself. Thank you.
Absolutely. And you all bring different perspectives already in your work. So I imagine that also helps to try to have some of those discussions that may not always be easy. Michelle, would you like to add on these topics?
Sure. I think Edna captured this lovely line about creating collaboration, creating rapport, and fostering respect. And I would say that this also is something that I think about acutely. And like Emily, I think this conversation just needs to be on the table at all times in global health collaborations, especially where we have collaborations that are being run between units in the UK or the US and South Africa or India. You know, there's all of that, all of the complexities of those collaborations that we need to be attending to, keeping respect and collaboration and openness on the table in terms of that stuff is also hugely important to me. So tricky, but I think Emily's correct to say, is if you keep it on the table all the time, then you can avoid some of the pitfalls of uneven relations when it comes to funding, for example. Yeah.
Absolutely. Thank you. We have a couple more minutes, so if anyone still wants to send questions. Edna, did you want to comment specifically on this question around implementation science, or do you feel it was covered in what you said previously? Maureen's asking a question about, okay, sorry, go ahead.
Sorry for cutting you short, Sonia. Thank you, Maureen, for that beautiful question. Here, I will say I'm the devil's advocate, because even in implementation science, I'll be singing about ethnography. So how I bring my anthropological expertise in implementation science, like what I'm doing in Malawi, the first thing is to conduct ethnography. So this research, or it's actually a big, broad implementation study that is being done, being funded by Bill and Melinda Gates, and is a long duration project, but I advised my team or my sponsors that I can't jump direct to start implementing things. I need to spend some time in the communities to do what I call knowledge creation. And this one I did using ethnographic approaches, spending time at the communities, trying to learn. And this is also engaging with the participants or people of interest to my research area. So after learning this, then I sit down with these people and we co-design programs together just to involve these people in every aspect, because as I mentioned, the solutions lies with them. All they need is just a bit of sensitization, a bit of awareness creation, a bit of support with some materials. But even these people at the community, some of them actually have resources that they could use to start transforming their lives. So what we do, other than knowledge creation, we try to change some of the opportunities that exist in communities into actions to improve people's health. An example I might give is that we are talking about HIV in Malawi, and everyone looks at the vulnerabilities and the negative things happening, but we don't look at the positive things happening. For example, some of these local people have ways of organizing football matches, or what they call football bonanzas in the communities. Some of these communities have dancing groups. So I look at these dancing groups as an opportunity for me to bring my ideas, and okay, I use their ideas, but then help them, support them, to tell them, look, use these dancing groups to communicate to people in your communities that this is the HIV is a problem in my community or in your community. Things are not really okay. So I have a broader knowledge from other studies we are doing, but with the communities I'm engaging in, I look at some of the opportunities that exist. We sit down with these communities and see how we can use some of those opportunities to improve their health. And so I leave it to them to implement. I only stand by the side to support them. So I don't impose my own ideas to these communities. Thank you. I hope, Maureen, that is answered your question.
Great, thank you so much, Edna. We're about to run out of time, so I just wanted to check if any of you have some final comments that you wanted to share that you didn't get to share yet, or are you happy with what we've covered? We've talked about everything from questions or coming up with questions to now what Edna was saying about also bringing things into practice. So any final comments there? Oh, there's a question here. I don't know if we have. Does someone want to quickly answer this question about safety issues from Kaylee, addressing safety issues in communities where you do research in, particularly in doing ethnography or spending time for extended periods of time?
I can answer that.
Thank you.
Well, I think this is really a huge question and a really big challenge. I myself have had some challenges in the field. Being in people's homes, my teams have had, in every place I've worked, some challenges. There's real challenges when you don't go to people's homes and you're not in the community itself and you're only at an institution. So we have done some research, for example, at the DPHRU research unit, when people are coming in and then they can stay there and do in-depth discussions and interviews. It's a really common tactic if there is not a large team, and it saves time, but also if there are, I have some, in my Soweto syndemic study, there were some things that happened that made my team feel unsafe. One of the ways we responded was, we ended up moving some of the qualitative work to the research station, but also the big surveys we were doing, we ended up having men and women. Every team had a man and woman on it, and they accompanied each other to each interview. So we didn't send one person into a home alone. Just honestly, being a young woman doing this research is different than being a young man, and there are different risks that I myself have confronted. So it's not uncommon. It's very common to not feel safe. So just in general, doing research all over the world, in the most elite boardroom to, the least wealthy community, right? So especially gender-based violence or threats are very common. So that often I feel, and our experiences are intersectional. So our race and gender and class all bring to us, we bring them everywhere we go. So, and ethnicity, you know. So those are real things to think about with your team. So it's good you're thinking about them. There's not one solution, but the care and attention for those who are working with you, for yourself, for your team, for the people you're interviewing. At times, there can be a risk for someone you're interviewing. For instance, if you're interviewing someone at home about trauma and their abuser is in the other room, that can be a risk for them as well. So in some cases, I do a lot of work on trauma and violence. And, you know, sometimes being in a research station in a safe space for the person being interviewed is the most important thing as well. So there's not one answer. The safety of the person you're interviewing is the utmost importance, as well as the people who are doing the research. So it's really complex. But just listening and being engaged with all participants and your teams and yourself, and being really honest about what is the best path for you is just essential. And that's also as you ask questions and as you're studying something, everything changes. And as Michelle said, you know, you listen to the questions and things shift over time. So even how you're doing things shift over time. So I hope that's helpful. There's not one size fits all for any of this. But I think that we all, you know, collectively can support each other. And if you ever have a question, I'm always available for mentorship as well. So thank you.
Thank you so much. Yes, that was obviously not going to be a quick question, but it was such an important question that I wanted to still cover it. So apologies for taking us over time, but thank you to everyone for staying. Thank you to Kaylee for that question, and to everyone else for participating actively with your questions and comments. And a huge thank you to all of our panelists for such an interesting discussion around engaging with medical anthropology. I think we've all learned so much about all the different ways in which medical anthropology can enrich in health research and qualitative research.